Okay, I think we've covered a lot of different topics today. Maybe some final words, if anyone wants to talk about what they're excited about in the future for small cell lung cancer, and we can stop there.
I think Tawfiq alluded to it earlier. There's been a lot of work into really defining subsets of small cell. And we might finally be in a place, especially an extensive stage, where patients have that time to better biopsy and define their tumor while they're undergoing what's going to be standard of care with chemo-IO to really inform second-line therapies and later.
I mean, for me, I think we still don't understand a lot of the biology of small cell. We know that, that they're largely, associated with RB loss, which is a poor prognostic factor, and similar to other tumor types, they just do really badly. But beyond that, we don't know why they're PD-L1 negative, have less immune cells. What else is going on with these tumors immunologically, even though they're otherwise similar to non-small cell lung cancer. So I think that efforts to sort of do more analysis of tissue as our technology has improved to immune characterize tissues, I think we'll be able to gain a better understanding of what to do for these patients.
One of the things that we're interested about is looking at, can we re-explore the VEGF pathway in small cell in combination with immunotherapy, kind of IMpower 150 small cell, so to speak, with carboatope in a combination with immunotherapy and a VEGF agent. I think really IMpower and Caspian have really set the stage and have shown that, yes, this combination is a combination that has activity, is well tolerated for patients, but how do we build upon that regimen? And so thinking about additional strategies, I think the VEGF pathway, maybe bringing that back again and seeing if we can capitalize on that for small cell.
Yeah, that's actually a great thought in terms of what tests can we do for this patient. Surprisingly to me, the Chinese were able to test anti-VEGF agent and got it approved. Second, third line salvage treatment in China with anlotinib. And the response rate looked reasonable. It was single agent anti-angiogenic agent. And we know that people have attempted that also in the frontline setting in combination with chemo. Unfortunately, those studies did not meet the bar that was set for them to move forward, but there was always that trend. I think the 3 trials that looked at combination of angiogenic plus chemo, you always saw the trend in favor of the angiogenic. It wasn't the other way around. So there's probably something there to be said for that strategy. The other thing are some of the promising agents, at least based on phase 2 data, that are now moving forward into phase 3. So we have the anti-GD2 antibody toxin conjugate, the distinct trial, that's completed enrollment, is a phase 3 trial now comparing that to standard of care agent in the relapse setting. And then we have the liposomal irinotecan, which was presented by Dr. Pasares at the World Lung, where the response was about 44% in relapse patients. Whether that would hold up in the randomized phase 3 trial, we don't know yet, but that is also ongoing. So I think, unlike where we were a decade ago, where this was a complete desert and nobody was interested, small cell is now becoming more interesting to both investigators as well as pharmaceutical sponsors, and I'm hopeful that all of these strategies will lead us forward and eventually result in new options of treatment for patients.
That was a great ending. Thank you. Thank you all for your contributions to this discussion. On behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative.